Well, I'd first like to thank Bjorn and Inga and Zilka and Veronica and Anne Sophie for inviting me to present at the conference and help in supporting my way here. Um, you have this handout in your bag that you were given, and I'm just letting you know because I tend to speak rather fast, but don't worry, it's all in the handout. And soon to be in the revised handout that will be posted at the website. Okay, the Infant Behavioral Assessment and Intervention Program, or IBAIP, is based on a theoretical foundation, individualized to meet the neurobehavioral organizational needs of the infant, developmentally supportive and process-oriented, family-centered, reflective in action, and validated by evidence-based research. It's based on the synaptic theory of newborn behavioral organization and development as conceived and developed by Dr. Heidelise Alls. As you can see at the top, we have the subsystems, the autonomic, motor, state, and attentional interactional subsystems. These subsystems interact with each other, sometimes impinging upon their relative stability and sometimes supporting each other depending upon the maturity and dismaturity of the subsystems. They also interact with the environment at large simultaneously. The focus of the IBAIP is not what to teach, but how to teach, how to facilitate learning, a process-oriented approach. The capacity of the infant to learn, according to Papusek and Papusek, requires an alert state, a graded presentation of stimuli, and a sensitivity to the feedback signals indicating limits of tolerance. It also requires an early intervention professional to learn how to read the neurobehavioral organization of the infant to support them in an alert state, to grade the presentation of stimuli and also, do you want to get that? Okay. And also to be attuned to the sensitivity and the feedback signals of the infant so that the early interventionist can provide the necessary co-regulation that the infant is seeking. The IBAIP is validated by evidence-based research thanks to the Herculean efforts of Marie Jean and Karen Koldevine, who conducted a randomized control trials between 2004 and 2009. This is the follow-up results of some of the studies that they did, moving from 6 months to 24 months and all the way up to 5.5 years corrected age. The IBAIP leads to improvement in intelligence, ball skills, and visual motor integration. Okay, the appropriate infant populations for the IBAIP are premature infants, medically fragile, infants developmentally delayed, neurologically impaired, or infants that have been exposed to drug or alcohol in utero. The IBA also may be used with older infants who are functioning between birth, a chronological age birth, and 12 months corrected age. IBA training is offered to all of the following professions who may receive the infants once they're discharged out of the NICU. IBA trainee prerequisites include experience with newborns or young infants, knowledge of neonatal medicine, infant development, family-centered care, and standardized testing. IBAIP training is most well suited for clinicians who are already skilled in their own particular pediatric specialty or whose current practice includes intervention with the high-risk medically fragile or infants born with prematurity or disabilities. Prior to the training, an IBAIP site coordinator is selected or identified, and the site coordinator assists in the collaboration with the trainer in the selection of the IBAIP trainees, distributes all training materials to the trainees, organizes all on-site training logistics, procures a room for all telephone and Skype conferences, and serves as a general liaison between the IBAIP trainer and the trainees. All right, this list of materials are sent to the site coordinator, who then invites the trainees to a meeting, and she distributes all these materials to each of the 8 trainees, and then I telephone in or Skype in and go through each one of these sets of materials with the trainees, and then they take them home and review them before the workshop. And this usually happens approximately 3 to 4 months before the first workshop is presented. All right, the core training components include the IBAIP program guide, which provides an overview of all the training, the infant behavioral assessment, or IBA, the IBA training manual, the neurobehavioral curriculum, the self-regulatory competence scale, and parents holding their baby. And I brought those materials, and they're right there at the sink if you're interested in looking at them. The IBAIP trains early intervention professionals to read and interpret the infant's behavioral communication skills. And this is the components of helping them to do that are the infant behavioral assessment, the operational definitions, and the training manual itself. To help them read the behavioral cues of the infant, of course, we depend upon the 4 systems as highlighted by Dr. Alls, the autonomic, motor, state, and attention interaction subsystem. And then the avenues of communication. These are the behaviors that emanate from the 4 subsystems: approach behaviors, self-regulatory behaviors, and stress behaviors. Approach behaviors are communication signals that the infant tells the interventionist that yes, the type of facilitation or the type of stimulus that you're presenting to me is fine. You can continue with what you're doing. Self-regulatory behaviors are behaviors that the infant utilizes to keep themselves together. And there's different ways they use these. They use them to concentrate, to cope, or to console if they become upset. And then finally, the stress behaviors are indicators to the early interventionist that they have gone beyond providing appropriate stimulus to the infant, and the infant becomes upset. This is a a front sheet of the infant behavioral assessment, and you can see the autonomic, visceral subsystems differentiated out into color, respiration, visceral, and neurophysiological indicators. The motor subsystem differentiated out into head and trunk and extremities, arms, hands, and legs. The state subsystem, which is classified into 9 states of consciousness. And then finally, the attention interaction subsystem with eyes, expression, oral and vocal behaviors. The observation itself, when we first start training the trainees, is about a minute in length. And then from there, it expands to about 5 minutes by the end of the training in the first workshop. But really, after you become more and more at ease with using the instrument, you can actually observe the infant for the entire intervention or caregiving or social interaction session. Based on what you observe using the IBAIP, a observational report is developed, and the pertinent medical history is identified. The ambient environment in which the interaction takes place is spoken to before the interaction, during the interaction, and after interaction. The neurobehavioral and integrity of the infant is documented. There's a neurobehavioral summary that is provided to speak to the neurobehavioral needs and strengths of the infant. And then finally, recommendations are proposed to help self-regulate the infant. These are drawn from the neurobehavioral curriculum for early intervention and also the self-regulatory competence scale. The neurobehavioral strategies from that curriculum are divided out into the environment, handling and positioning, and cue match strategies. The self-regulatory competence scale moves from optimal, high, moderate, low, minimal self-regulatory competence. This tool is used to help the interventionist identify where specifically in the neurobehavioral curriculum that they should start drawing upon the strategies to support the infant during an intervention session. Neurobehavioral strategies. So these are strategies for supine upper lower trunk extremities. So in this case, we have the infant laid supine, the airplane configuration of the arms out to the sides away from the body. The child is what we call sitting on air, legs kicking up into midair. Self-regulatory is coping. She's averting her gaze from the interventionist. The child is in an alert or awake state, which is much different from interactive alert, where you're engaged in what is being shown you, and the attention is not focused for learning at all. So the adult supports foot clasping, bracing, and tucking of the lower trunk and extremities by gently holding the infant's feet. This in turn facilitates an interactive alert state. She's now looking at the interventionist, and the infant's arms, however, still continue to be splayed out to her sides. So the adult supports foot clasping and bracing by gently holding the infant's feet and brings the infant's hands to midline. The infant holds on to the interventionist's fingers, and the interactive alert state is maintained. The adult continues to support the hands to midline and holding on. However, support of the feet has been discontinued. The infant is now able to foot clasp and brace on her own. So if the child can take over for herself or himself, that's what you want to help them do. So you're not always providing all this co-regulation. You grade it depending on what the child can do for themselves. The adult presents the infant with a toy as she continues to support hands to midline and holding on. The infant continues to support her own feet in foot clasp and bracing, which assists her to concentrate on the presented toy. And finally, the adult continues to support one of the infant's hands, releases the other hand so the infant can then move on to reaching up and attaining the toy. Holding parents holding their babies is our parent materials that we've developed. We teach IBAIP trainees to facilitate and validate parental perceptions of the behavioral cues of their infant. When we first start out visiting the infant about 1 week before discharge, just to say hello and get to know the family and their baby, and then approximately 2 to 3 weeks later, we give them a call once they've settled in and nested into their home with their friends and their family to make an appointment to go out and be with the parents. And usually our first visit is focused on asking them if they'd like to share their NICU experience. Because oftentimes these parents who have lived in the NICU anywhere from 4 to 12 months have never had the opportunity to actually share their experiences. So we provide that. We also provide them with a very simple sheet that just states, this is what Johnny did today. Because oftentimes the parents who have been living in the NICU, all they've heard are all the bad things that have been happening to their baby. We now try to help them see all the good things their baby is now doing at home. So that could be they bring their hands to their mouth, they smiled at mommy, their diaper rash is gone, they're off antibiotics, etc., etc. And sure enough, when we come back to see that family the following week, they're standing with a list of their own of all the things that they saw their baby do. We also have a number of neurobehavioral considerations with the environment, handling and positioning, and cue-match strategies. And just to give you a few examples of that, feelings of oneness, helping the parents and supporting the parents and getting to know their baby and supporting the baby to get to know mommy and daddy. Let the world go away. Yes, there's dishes to be washed, the lawn needs to be mowed, the clothes need to be washed and dried, etc. But this is an opportunity to take time for you and your baby to get to know each other. And then also protecting things that we hear or the light and activity level in the environment. So if the sound level is disorganizing for the baby, then we provide suggestions on how you can tamper that down. Homework assignments. This is all in the handout, so I'm not going to go through all of these. The homework assignments occur after the first workshop. It's followed by a second workshop approximately 8 months from after the workshop 1. And then IBAIP workshop 3 is a 4-day certification workshop approximately 6 months after workshop 2. Basically, IBA training takes approximately 12 to 14 months to complete. The training responsibilities and time commitments. All of these responsibilities have been added up, and it's been estimated that to participate in IBAIP training, it takes approximately 200 hours. IBA prospective trainer prerequisites, a minimum of 5 to 10 years of clinical experience. They've attained a minimum of a master's degree in one of the following disciplines and are successfully been trained and certified as an IBA professional. This is for achieving IBA IP sustainability, training the IBA trainer. Now, to become an IBA trainer, you are an IBA professional first off, and then numbers 1 through 6, the master trainer and the prospective trainer work together to present another full workshop. And then the 7 addresses the fact that the trainer now, the prospective trainer now, takes on and conducts an entire workshop by themselves. Costs. Subtotal of training materials and shipping fees are $5,000. So subtotal of IBA trainers fees are $13,000. Estimated trainers fees with regards to the travel expenses are estimated at $4,470. And the total cost of IBAIP training is $22,470 or 20,050 euros. So if you have 8 IBAIP trainees, you divide that total, and the total cost of trainee is $2,800 or 2,500 euros. And I just want to talk about one additional IBA training component that we've added based on team building for transition and the transactional family systems model project, demonstration project, that I developed in 1986. We bring the NICU professionals and community early service providers together for one day. And their job is to develop a transition action plan to ease the transition of the infant and family from the hospital and ICU to home with eventual linkage to community services and early intervention professionals. Issues that might be addressed in the development of a transition action plan includes written plans for family support at discharge, a nursery-generated individualized family service plan or IFSP that then can be easily integrated into the IFSP later, generated by community early intervention services, medical, developmental, and neurobehavioral reports to be shared with the community, the pediatrician, and other community service providers, and establishing links between these community service providers and the hospital NICUs. So the ultimate goal is to provide a seamless transition of developmental and neurobehavioral support from hospital nursery, and if you're so fortunate enough to have a hospital that is engaged in NIDCAP training, and to community services and early intervention professionals who have had IBA training. So you have a seamless transition plan of neurobehavioral support from hospital to home to hook up with community services. Thank you very much.